Dr. Kind invitation, Manisha, Rupesh, and I will try to cover about toxoplasmosis. It's a quite difficult issue. It's important to remember the cycle of the parasite, but more important than this is to consider that toxoplasmosis can be a different disease. So it can divide into congenital toxoplasmosic, systemic disease when you have the acute disease. So we have fever, skin rash, lymphadenopathy. The systemic disease in pregnant women. So you have the risk to congenital toxoplasmosis. Also, ocular toxoplasmosis, immunocompetent individual. So the treatment will be different. The diagnosis will be different. The ocular toxoplasmosis in pregnant women. So this is another issue you have to address. The treatment will be different from immunocompetent individuals. The toxoplasmosis in immunosuppressed individual and the neurotoxoplasmosis. So you can split the toxoplasmosis in different diseases. So here is the clinical manifestation of congenital toxoplasmosis with the Sabin triad, with hydrocephalus, calcification, and retinochoroiditis. This is a typical lesion in the macular area. And it's really a disaster to see this kind of involvement in the central nervous system and in the macula of both eyes. This is the siblings with congenital toxo. And what's important to avoid the congenital toxoplasmosis is to detect the acute infection in pregnant women. So you have the prophylactic measure and regular serology tests. So in France, you do this monthly, in Austria quarterly, and in Brazil, unfortunately, have no obligation to do such regular serology tests. So it's important to know that transmission risk of congenital tox is approximately 30%. So how far the pregnancy is going, so is the highest risk to get the toxo, but the less risk to have a devastating infection. So it's important to see that people that's never infected by tox, there's no risk to have congenital toxin. If you have chronic infection, so you have a lesion in the eye, a scar in the eye, there's no risk to transmit to the fetus. But you have acute infection during pregnancy or 3 months before, you have the risk to transmit congenital toxoplasmosis. So the diagnosis of congenital tox in the fetus is based on the PCR in the amniotic fluid, or after the born, you can do the IgG, or you can follow this IgG for a year. I will show here a study led by Dr. Vasconcelos in Minas Gerais in Brazil. It's a state, they have 21 million people, and they try to screen all newborn for congenital toxo and did IgM in dry blood, one sample. So they screen 146,000 newborn and have 190 positive kids, and they saw in the ophthalmic and pediatric clinic 178. And they found 9 patients with previous suspicion, 39 with calcification, 10 with microcephalus, and 12 with hydrocephalus. What is important in this study is that they found almost 8% with retinochoroiditis, much more than previous studies published in the literature, and almost 6-3 with bilateral disease and 111 with macular disease, and 47 with active retinochoroiditis. So you need to treat this patient because of the eye, but not only because of the congenital disease. So here is how to treat the patient with congenital toxo. I'm not keeping this slide, but it's important to say that all kids with congenital tox has to be treated for 1 year with a specific treatment to avoid neuro commitment and ocular involvement. Talking about ocular toxoplasmosis, is quite common in Brazil. We have a survey from 2010-2015. We saw 2,972 patients in the National Institute of Infectious Disease, and almost 75% were toxoplasmic retinochoroiditis. If you can compare with Australia and Saudi Arabia, you see much more cases of toxo than these other countries. So what's challenges in toxoplasmosis is that all patients ask you the same questions. How did I get this parasite? And this is quite difficult because we know how to get the parasite, but don't know how this particular individual get this parasite. So it's very easy when you have outbreak in a certain region in the country, so you can study this region and get the risk factor. For example, in Erechim, as in the southeast of Brazil, you have they eat a lot of raw meat, so it's quite common to have this. In Rio de Janeiro, it's more common to have unfiltered water, so it's very, very difficult to see how one special person get the parasite. Will it affect the other eye? It's quite common to have this question. If you think of the transmission of the toxo and how they spread through the body, you should expect it to have the toxoplasma in both eyes. But what we see normally, it's to affect only one eye. Will it relapse? It's quite common to relapse. And that's why we discuss later on prophylaxis. And what should I do to avoid relapses? Really, we don't know yet why it relapses. And what we're trying to do now is to do the prophylaxis to avoid relapses. So this was a survey we did in Campos dos Goytacazes in Rio de Janeiro, just to show in this population, the IgG titers is around 90% in poor people. And just in the early, you can see here in this graph, as almost 80% in the IgG. And when they got older, will be around 65% the IgG positive. So in Brazil, it's not very important to have a positive IgG because the majority of the population is positive. So the risk factor for Toxoplasma gondii in this area is not undercooked beef, but drinking underfiltered water at home. So this is another place in Brazil, have an outbreak in the 90s, showing the water reservoir for a part of the city. And there are a lot of cats playing in this area, and the half of the city was infected by toxoplasmosis. The diagnosis basically is a clinical diagnosis. The serology can help us more to exclude the diagnosis rather than confirm. If you have a positive IgG, just say that this patient had a contact with the toxoplasma, but not the disease is a toxoplasma retinochoroiditis. Diagnostic vitrectomy we leave only for very difficult cases, and it's important to pay attention to the elderly, HIV positive, and immunosuppressed patients. That's the clinical presentation can be a little bit different. One single foci of retinochoroiditis, you can think of primary ocular toxoplasmosis. This is not common. You see around 10% of the patients with IgM positive following fever, rash, and lymphadenopathy. And usually after treatment, you can see there's almost no scar where the area of the healed lesion. This is the classical toxoplasmosis retinochoroiditis. It's always important to see this hyperpigmented scar to confirm the diagnosis. Usually in Brazil, if you see one case like this, we even don't ask for serology and go straight forward for the treatment. You can see here other examples of classic active recurrent retinochoroiditis. The presentation is quite different, but you always see this hyperpigmented lesion and area of active necrotizing retinitis. You can see this atypical presentations in, as I mentioned before, in the elderly, HIV positive and immunosuppressed patients. You can have to make the differential diagnosis of acute retinal necrosis, viral retinitis. So it's important to keep in mind these large areas of retinitis and also bilateral disease. Once again, this large area of retinochoroiditis. You don't see much these cases in adults, immunocompetent patients. You can see neuroretinitis also. And to make the diagnosis, as I mentioned to you, the most important is the clinical picture. But you can use also the Goldman-Whitmer coefficient and polymer, the PCR. It's important that the PCR in toxoplasmosis is not very good. The sensitivity and specificity is not, the sensitivity is not very good. It's very good for viral, but it's not good for toxo in the AC. So if you get it more sensitivity, you have to go for the vitreous tab. Another difficult issue is the treatment. There are a lot of studies in the literature trying to say that one antibiotic is better than the other, when you have to treat, how you treat the patient with toxo. The Brazilian Uveitis Society, they say that you have to treat the macular and optic nerve lesions with thick enough vitreous haze, a decrease in visual acuity more than 3 lines, and large area of retinitis. I usually treat all my patients with active toxoplasmosis retinochoroiditis, independently where on the size of the disease or the visual acuity. Prophylaxis is another important issue. You cover this later on. So the treatment, usually they use the what's called the classic treatment, the pyrimethamine and sulfadiazine, but there's a lot of alternative treatments, the Bactrin, clindamycin with pyrimethamine and sulfadiazine, pyrimethamine and azithromycin alone, intravitreous clindamycin, and several studies were done, and no one showed any difference between these treatments. Oral steroids, I usually use my do my treatment with oral steroids because I want to clear the vitreous and try to control very quickly the inflammation to avoid a complication like epiretinal membrane, vitreous detachment, macro hole. I will show you the number of complications we have in toxoplasmosis retinochoroiditis, but there's no clinical trial showing the benefit of steroids as a adjuvant therapy for ocular toxoplasmosis. In a survey did in Brazil, apart from the society say that you only have to treat large areas, the visual acuity, the lesion close to the macula and the disc. The specialists in uveitis in Brazil, almost 70% treat all cases. And interestingly, you don't see any difference between the therapies, sulfadiazine, pyrimethamine, or Bactrin or clindamycin, but the majority of specialists prefer to use the classic treatment in patients that present with central lesions or the immunosuppressor or acquired and atypical forms. So it's difficult to say that's really no difference. There's no difference between the therapy in published in the literature, but in practice they use more the classic treatment when we have more sight-threatening lesions. It's important also to say that the risk of side effects is quite high and we did a study with more than 200 cases in Brazil, and we have 85% present with some side effects to the treatment of Toxoplasmosis retinochoroiditis, most of them related to steroids, but it's important to remember that sulfa and pyrimethamine can lead to some systemic side effects. The prophylaxis is something that we are using more regularly since Felix and colleagues published this study in the American Journal showing that the prophylaxis with Bactrim reduces the relapses after 3 years, and then Felix followed these groups to 6 years and published the same results. So we are doing prophylaxis for patient that relapses a lot. So one patient, for example, that you treat with specific treatment and just after 1 month or 2 and relapses. So we present this possibility for prophylaxis. We do Bactrim every other day for a year, or in patient that's only eye or a lesion very close to the center of fovea. So we say that there's a possibility to avoid relapses. This is not guaranteed that will work, but there's some data that's a benefit to doing prophylaxis. Remember, there's a long-term doing Bactrim. There's a lot of side effects, so you have to discuss with the patient the pros and cons to do the prophylaxis. Another important issue that's a lot of people based on one paper published a long time ago start to do prophylaxis prior to intraocular procedures. So we decide with Dr. Pavesio to do a retrospective study in our patients who underwent ocular surgery, and we saw no relapses in 65 patients. Only 4 patients relapsed after 3 to 17 months, showing that there's no relation between the surgery and the Toxoplasmosis relapse. So we decide not to use prophylaxis anymore. And if you think of the number of cataract surgery and the number of patients with scar in the back, we don't see much relapses in ocular toxoplasmosis following intraocular surgery. And there's a lot of complications you do see in toxo, vascular occlusion, neovascular membranes, retinal detachment, macro hole, epiretinal membranes, and visual field defects. And that's why in the majority of patients, we do use steroids to try to avoid vitreous or improve the vitreous inflammation. In 230 patients in the National Institute of Infectious Diseases in Brazil, we had 33, almost one third of the patients present with ocular complications. And the most common, the residual visual vitreous opacity, and the majority of these patients needs vitrectomy to clear the vitreous. Epiretinal membrane is quite common too. Retinal detachment and macular roll, these are more uncommon complications. So some examples of vascular occlusion and neovascular membrane and visual field defects. This patient was very unlucky to have this lesion just very close to the disc and causing this visual defect, and a macular hole with this vitreous stretching and led to this macular hole. You can see here, the lesion is not that close to the fovea, but because of the vitreous, the vision dropped a lot. So thank you very much for invitation. I hope I cover a few things.